Thank you, Ayako, and thanks everyone for joining this evening for you, this morning for me, actually connecting to you from Geneva, Switzerland today. I'm really happy to be here. Unhappy that I can't be there in person, but we'll hope to see you another time. I thought what we would do, and you may know that we're scheduled for 2 lectures over the next week. So today and then at the same time next Monday. Today, I thought I would give you about an hour's worth of discussion on some big picture thoughts about controlling outbreaks. And of course, this is in the forefront of everyone's mind these days with the coronavirus pandemic. It's something I've been working on for quite some time now in different outbreaks around the world. So we'll talk about that for an hour, and there'll be 30 minutes for questions. And Ayako has gone through the different routes to ask your questions. Please feel free to overcome your shyness and do ask questions. You know, happy there's no stupid question or foolish question. It's this is your chance and our chance to exchange information and thoughts. And so very interested to hear your questions and any thoughts that you may have. And then next week, we'll go over a little bit. Today's kind of the background of outbreak preparedness and response. And then next week, I thought I would talk a little bit about the very changing international architecture of how we do outbreak response and what we do with our team in the UK. Those of you who are familiar with accents, you may notice that my accent's not a British accent. I work in the UK, but I'm American by training and grew up in the United States, although I haven't lived there in some time now. But next week we'll talk a little bit about kind of prospectively, how do we respond to outbreaks? And so I'll start in then. I'm going to try to share my slides here. I think, let me just find that. Okay. And so, as I mentioned, I'm going to talk about outbreak preparedness and response and kind of some examples of things that we've confronted over the years and the various challenges that they bring. This is a statement of a few years back now in 2018. And I'll read it knowing that it's sometimes hard to see this online, but we need to be proactive. We can't wait until there's a large problem, and we can't say, well, it's not our business here if it's somewhere else. When we have outbreaks anywhere in the world, it's really everybody's business. It's a threat to everyone, and we need to react on a global scale. The big risk is when we have an actual new pathogen, a novel pathogen that has never existed before. And so again, I'll remind you that this is 2018, quite a bit of time before coronavirus, the present coronavirus outbreak and pandemic began. And this was something that this is something that I said in an interview back in 2018. And I don't put this up there to say that I'm any more smarter or any smarter or can see the future better than anyone else, but just that, of course, pandemics are not something new. We all knew that pandemics have existed in the past and would come in the future. So that familiarity or that knowledge is not something new. However, we unfortunately are not very good at remembering history and preparing for it. And so we've had pandemics in the past. Of course, the biggest one that we've had in the last century was the so-called Spanish flu, or that happened in 1918, and now we're again from a very large outbreak or pandemic from a new source. So unfortunately, we're learning some new lessons here with COVID-19, and I'm not going to focus too much on COVID this evening for you, because I think you're probably saturated with this and getting it all every day and knowing what's going on. We can discuss it in the discussion at the end of the lecture and next week if you have specific questions. But I think you're familiar that, unfortunately, we're in a very dire, difficult situation with COVID around the world. Certainly here in Switzerland and the United Kingdom and across Europe, certainly in the United States and many other areas of the world as well. So we're far from finished with that. But I think there's some principles from other outbreaks and pandemics that we need to understand. And I put this slide in here really just because I liked it. It just actually happens to be by chance that it's Japanese. I use it for other lectures, so I didn't prepare it specifically to talk with you, but I just like the different waves that you can see here of that are coming in and threatening these boats on the ocean. And so you can see bigger waves and smaller waves. And so, that's really where we are in the world. People talk about a second wave of the COVID-19 pandemic. And in places we have a second wave, certainly here in Switzerland and the United Kingdom. But nevertheless, really, it's a series of waves across different areas of the world. And I think will be a series of waves. And some of them are sadly large tsunamis, and other ones are smaller ones. But we're going to be dealing with this, I think, with different size waves into the foreseeable future. Certainly going to be a challenging winter in the Northern Hemisphere for all of us, and many other places as well. But of course, we can do something about this. We haven't, some countries have dealt with this and more effectively, and others less effectively. I won't specifically get into the politics of that right now, although I will say that I think health, we have to recognize, is inherently political. And so health policy is made by political leaders. And so what we're seeing in this outbreak is that the politics do matter very, very much, and that sound political leadership makes a big difference in terms of protecting us from outbreaks and pandemics. So we're dealing with these things. The COVID-19 is the biggest one, but there are many that we've had to deal with over the course of my 25, 30-year career so far. And almost all true emerging diseases are zoonoses. And so that means a new zoonosis, of course, is a pathogen that is maintained in animal sources and then comes into humans. Humans generally play no role in the maintenance of that particular pathogen. They are just incidental hosts. And if we're unlucky, they get into humans and then they can have onward transmission. These are some photos of work that I've done related mostly to Ebola and Marburg viruses that are maintained in bats in different areas of sub-Saharan Africa. You can see actually the one that shows the bat flying out of the cave. All the little white dots that you see behind there are bat eyes looking back at you. So probably tens of thousands of bats in a cave in the Democratic Republic of the Congo, where there was a Marburg virus outbreak years ago. So really all our concerns in terms of pandemics and outbreaks come from zoonoses, with an exception that I won't deal with. The other exception, and those zoonoses are almost exclusively viral diseases. The exception that I won't deal with are bacterial diseases, is multi-resistant bacteria. And so those also can cause outbreaks and a risk, a very significant risk to humans. Those are generally created by humans, by the antibiotics that we give liberally to humans and to animals in livestock. And so it's a very different process. But what I'll focus on are the viruses that come from animals into humans and then cause significant disease. And those, we won't go into the virology of this, but those are generally RNA viruses. And the reason that they're RNA viruses is because the replication of RNA viruses through the RNA polymerase is less faithful in terms of putting in base pairs than the DNA polymerase and DNA viruses. And so when you have a less faithful or less accurate polymerase that puts in different base pairs, and so you have a diversity of different viruses that can come out. And many of those may not be transmissible or may not even be viable formats or forms of virus, but nevertheless, here and there, you get a virus that comes out. And whenever you have diversity, you have the chance of having something that will come out that has all the characteristics which we would not like. Those characteristics, of course, are something that is transmissible between an animal to a human, and then transmissible between humans, and then in the worst case scenario has high pathogenicity in terms of causing disease. There are probably, these sorts of events probably happen quite frequently, but we're just not aware of them because those introductions don't result in the onward transmission that I mentioned. And so you probably have, for people who have direct impact or direct contact rather with wildlife and domestic animals and livestock very frequently, there are probably quite a few introductions of viruses into those people that either may be non-pathogenic, and so we never know about them, or not pathogenic enough that a person ever comes to recognition. So they may be home sick for a day or two with fever or diarrhea or whatever it may be, but never come to a doctor and get better and no one ever knows about it. Or the virus is not very successful, or we're not unlucky to have the virus pass between one person to another to create an outbreak. So there's probably a lot of aborted events, if you will, where these viruses get into briefly from animals into humans, but the circumstances are not right for them to pass on and cause large outbreaks. And then here and there, we have the worst case scenario. I wouldn't necessarily say that COVID-19 is the worst case scenario, but of course it's a bad scenario where you have a virus that got into humans from clear evidence that these viruses, coronaviruses, these species and strains of coronaviruses are maintained in bats. And from bats into humans, it can be directly or indirectly. And so what I mean by that, it can be from a bat source. It seems odd to many people in the world, but bats are hunted for consumption and for other reasons. And so it can be directly from that, or it can be indirectly from the bat, for example, that would infect an intermediate animal that then could be hunted by a human or contact with humans in a live market or other settings. And so one way or another, these viruses get from their original source into humans, and then we start to have problems. And you're all familiar, looking at this next slide, of examples of emerging and re-emerging diseases around the world. We use this term quite liberally these days in terms of emerging diseases. Some of them are truly emerging, and what I mean in terms of the most classic, strict sense of an emerging disease is something that didn't exist in human populations before, but has come in and is really something new. And so COVID-19 is an example of something that's really new. Other times, it's really not so much the pathogen that's emerging, but our understanding that's emerging of something that may have been there or circulating for a while, but now we have just discovered it to see it as something new, or we have changed our behavior to give it inroads into places where we didn't see it before. I'll mention that as we go forward in a few examples. And it may also just be more seemingly small changes that come up. So for example, a new diagnostic test is developed, and so people start to do a diagnosis or make a diagnosis that wasn't available before, or a new investigator comes to Kyoto University who's interested in a particular disease and says, okay, I'm really interested in hepatitis E, and so let me look very carefully for hepatitis E. And people perhaps may have not seen a lot of that before until someone comes in and starts looking for it. So then we tend to say this is an emerging disease, and people will publish papers that say we had many cases last year and very few cases the year before that. May be true, but it may also be true that the cases were there but just not recognized. And we all recognize that for those who are clinicians in the group, there are many people that we've treated over the years. One would certainly agree, and even if you're not a clinician, can understand that every time you've had a fever or a bout of diarrhea or even gone to the doctor, it's relatively unusual that the doctor comes back and says, you have this specific pathogen or this specific virus, right? And so many times people get better, most times, fortunately, people get better from their febrile illnesses or diarrheal illnesses or upper respiratory illnesses without ever knowing the specific pathogen that it was. And many of those, of course, most are known pathogens, and adenoviruses and rhinoviruses and influenza viruses, but we can never really exclude that different things are going on. And when we do studies where we look for all the known pathogens, we will inevitably find that we don't get it doesn't explain all the illnesses. So if you take 100 people that come in to a hospital in Kyoto with a respiratory illness and say we're going to use a multiplex assay to look for influenza and rhinoviruses and adenoviruses and different things that cause upper or lower respiratory syndromes, we'll diagnose a lot of those people, but not all of those people. And so the ones that we don't diagnose may have pathogens for which we circulate, but we don't recognize. So lots of things going on in the world, and will continue to go on in the world because, of course, as long as we have wildlife and animals in the world and livestock, we have a mixing pool of all these pathogens that will replicate and come out and have the chance for something relatively new. And when it comes out and it's new, then it causes problems for us. And of course, the reason that causes problems for us is because if it's new, then there is no immunity in the population, right? So something that's been around for a long time, then we've developed a certain degree of immunity across usually fairly large numbers of people. But then when we have something completely new, so no one has ever been infected with a COVID-19 virus to our knowledge before about a year ago in China. And so, of course, the global population immunity when that virus first came into humans was zero. There may be some degree of overlapping immunity from previous other coronaviruses, but nevertheless, the real danger of these novel pathogens is that there is no underlying immunity. And as I mentioned, these come, and we have to look at this and I'll emphasize this as we go on with the lecture, it's not only about the new microbes that come out, it's also about the ecological factors that allow them to come out. In terms of these days, we think a lot about global climate change and the temperature changes, and also habitat perturbation, people going into pristine forests or mines and places for economic reasons that they didn't used to do. Genetic and biological factors of who's susceptible to this, older populations that may be more susceptible that we didn't have in areas of the world before, certainly a factor in Japan. And then physical, environmental factors, and then never to be forgotten, the social, political, and economic factors that drive these. And so it's always multifactorial, and we have to take each pathogen separately and to consider the many, many influences that ultimately conspire to make a disease emerging or an outbreak or pandemic happen. And I'll give a few, and we'll talk in a little bit more in depth in a couple different examples. And I'd like to focus, like I say, I won't talk too much about SARS-CoV, and I'm looking at this slide now and seeing that it's a little old. We're over 25 million people infected now. I need to update that, but that was updated really relatively recently. So of course, as you all know, this is moving fast. But I'd like to take a look back at some of the other large outbreaks or pandemics in our relatively brief century so far in the 2000s. And those include SARS coronavirus. And there are different ways of looking at this. And so if you look at SARS coronavirus and the graph there, or the figure, I have the cases, and the CFR is the case fatality ratio. And so, of course, the numbers are important, how many people contract a given disease. But then, of course, the other question is how many people get sick or die from a given disease. And I won't, we're not in a position I won't call on you today, but I can often fool people when I say, what's a more dangerous virus in terms of transmission, measles virus or Ebola virus? And most people say, oh, Ebola, that's a very dangerous virus. And it is a dangerous virus, of course, if you catch it. But in terms of catching it, it's much easier to transmit measles or COVID-19 than it is Ebola. So that the number of cases in some of these viruses can be quite high because their transmissibility is quite high, but their pathogenicity or lethality may not be as high. So SARS-CoV-1 that caused SARS in 2003, starting in southern China and then across to Hong Kong and Vietnam, and then with some introductions back into Beijing in China and various places in the world, Toronto, Canada, some transmission in France, limited transmission in the United States. If we look at this now, of course, we'd say, well, that was a relatively small event, 8,000 cases over the course of that outbreak. But it was a fairly virulent virus, much more virulent than SARS-CoV-2, where we had almost 10% case fatality. And then if we looked at the H1N1 influenza pandemic that happened in 2009, it was really the opposite situation. And up until the very recent COVID-19 pandemic, and I'd give similar lectures to this, I used to say that the 2009 event really was the scariest event that I'd seen so far, because we had a very transmissible virus, which we detected very, very early on, detected in northern Mexico, and then came up into southern United States, and from there spread virtually throughout the world. And despite detecting it very early on, and despite knowing that this virus exists and what was causing disease, we really failed to prevent it from circulating almost throughout the globe. But we were fortunate in that it turned out to be a very non or avirulent virus. And so if we look at the case fatality ratio, it's far less than 1% for that virus, elevated in certain high-risk groups such as pregnant women, but nevertheless, we really kind of, what we would say in English, dodged a bullet there that could have been a very serious event, and still was a serious event. And of course, if you do the numbers, even if you have a virus that is not particularly virulent, but nevertheless affects millions or billions of people, so 0.03% times 200 million. I'm not smart enough to do the math in my head, but the absolute mortality of these events can be very considerable if we think about large numbers being infected. And then the next example, 2013 Ebola virus. You all were aware of this, certainly, with the large Ebola virus outbreak in West Africa. And this was really the opposite sort of event. So Ebola virus is, contrary to popular belief, not a very transmissible virus. It requires direct contact with blood and body fluids, and it requires that contact really from a person who is in the very severe stages of illness. And so that means that they're in days 3 or 4 of illness, where they start to have diarrhea and nausea and vomiting, and sometimes bleeding. And so people who have direct contact with them, either usually caretakers in the home, members of the family, or unprotected healthcare workers, that can be, of course, a very dangerous disease where we see case fatality ratios. I put over 40%, but in some outbreaks they can be 60, 80%. So a very dangerous disease. We won't have time to discuss it this time, but we are bringing that down with some new tools in terms of therapeutics and also vaccines for Ebola virus. So a lot of exciting, positive things happening for that. And then, of course, the example of SARS-CoV-2, which is, unfortunately, has the transmissibility similar to an H1N1 influenza virus. So we're looking at millions of people that are being infected across the globe. Really, even that 25 million that I put there a few weeks ago is a very significant underestimate, because that was cases of COVID-19. That doesn't take into account all the asymptomatic or mildly asymptomatic infections that we're seeing. And as the data come in, we're seeing that there's quite a few of those. So for each person who has symptomatic COVID-19, we're probably looking at 5 or 10 people who have been infected but had either mild or asymptomatic infections. And so our case fatality ratio is relatively low for that, and at least relative to Ebola. But because we have so many people who are being infected, of course, we have a very serious situation. And then if we looked at case fatality ratios that are age stratified, we see that it's much higher if we get into certain high-risk groups and elderly people and others that have some comorbidities. So a very serious situation, and that we're seeing and dealing with that. So different examples of how these different things can play out depending upon the particular characteristics of the pathogens. I'll give you a little bit more detail of each one. So this was the SARS outbreak that happened in 2003. I spent most of this time in Vietnam at that time, working with the U.S. Centers for Disease Control and Prevention. And this was another example of a truly emerging pathogen. And so about a month or so probably after cases were first identified not in China, but identified in or mainland China, but across in Hong Kong and then Vietnam. A new virus was discovered and sequenced, and so we saw that that was SARS coronavirus, and it did not sort with any of the previously known coronaviruses. There are quite a few coronaviruses that are known prior to both SARS and to COVID-19. Most of them are animal sources, and so they cause mild disease for the most part in swine and rats and different animals and birds. And then this new virus that we called SARS. SARS was severe acute respiratory syndrome, from what the initial clinical presentation turned out to be really a new thing that we had not seen in humans before. Sometimes it seems new, and if we go back at the end of an outbreak and look in different populations and look for antibody tests, do antibody tests and look for circulation, we can see that perhaps something was there before, but there's no real, those studies do not suggest that SARS coronavirus was existing in the population in Southeast Asia prior to entry into humans in 2003. And so this was an example of a truly emerging pathogen. And I've already given you the numbers here, but this is just, if you can see this, the geographical spread here. Most of this was in Southeast Asia and China and Hong Kong, but imported cases into Thailand, Singapore, various places around the world. Outside of Asia, the biggest problem was in Canada, with a large cluster in Toronto. But we again somewhat dodged a bullet there. 32 countries, about 8,000 cases of 10 and a 10% case fatality ratio. But this was fortunately not as transmissible a virus as COVID-19 is, and so we didn't really have a global problem. So what did we learn from that outbreak? There was rapid mobilization of global expertise, and so that was a very positive thing. There was overall good international collaboration. The technology really came through, and that's one of the high points, I think, and reasons for optimism, that we're going into a stage where laboratory capacity and diagnostic assays to detect the pathogen really, have come on through different modalities and unbiased sequencing and different things. So no longer is it really our major challenge, as it has historically been for the last 150 years, to say, okay, what's causing this? What's causing this? We can actually learn what's causing something relatively easily and rapidly these days. And so, so that we learned, some positive things there. But we also had some problems. Not all countries were originally forthcoming with information on disease, and that, so it has to be said that this outbreak started in southern China, and China was not originally sharing data on that, and not forthcoming in the early phases of what was happening there. And so it took some time to really engage and learn what was going on as things got across into Hong Kong and Vietnam. So it also exposed the weakness of our surveillance systems, and then still global coordination is always challenging, and some things to learn there. Some examples from the pandemic H1N1, also sort of inappropriately called the swine flu. This was a virus that had come, as influenza viruses do, that mix and match in different, usually they take on different properties of influenza viruses that infect humans, birds, and pigs or swine. And when they do that and have recombination events, they can come out with, again, something really new and dangerous. And so that's what happened here in this virus that was a triple reassortant containing components of swine, avian, and human flu viruses. We understood that this was happening relatively early, and as I mentioned, as it came into from Mexico into the United States, but we were really unsuccessful in stopping this from going throughout the globe. And if you can see here, the reddish color there of all the countries that are impacted, and you can see the number of cases. So really, this was a true pandemic. Places where there were not cases, some of that may be surveillance artifact, that there wasn't enough surveillance in order to detect cases. Again, keeping in mind that most cases were mild and didn't come to medical attention, and would have overwhelmed systems if they had. And then also noting that most of sub-Saharan Africa, or much of sub-Saharan Africa, no cases were reported, that it may be a combination of lack of surveillance, but also may indicate that at that time in 2009, and still true, but less true than it was, that international travel prior to COVID-19, of course, international travel to sub-Saharan Africa from Asia and the Americas and Europe is less than other continents. But as I mentioned, that has changed very, very considerably in the last decade. And so we're not seeing Africa to be protected from relative isolation as it may have been in the past. Moving on now to a few examples from the Ebola outbreak in 2000, began in late 2013, first detected and reported in 2014. And so this was a virus that used to really cause small isolated outbreaks that were devastating to villages that were involved, but not something that we saw on a larger scale. And, prior to the West Africa outbreak, the largest outbreak, and I was very engaged in this one in Gulu, Uganda in 2000. This was considered the big one, and it was 425 cases that lasted 3 months. And so that was the big outbreak until this major event in West Africa. We saw this happen. And this is just to give you an idea of this, very significant epidemic curve, and starting in southern Guinea and then getting into Liberia and Sierra Leone across the borders, and then spreading to other places. And these generally come into humans, again, either although it has not yet been 100% confirmed, we have the assumption, I think, based on some evidence, that Ebola viruses are maintained in bats. We don't know the specific relationship, but they usually come in to humans in relatively rural areas. And this is a photo I took of when I was in Guinea at the time, an area that I've worked for many years prior to this outbreak on Lassa fever programs. But you can see, this is a rural area. I was actually going with a colleague on this motorcycle to visit one of these little girls here who we knew her mother in a different setting had Ebola. And so we didn't know if the girl was infected or not, and needed to find her to try to see her health status. Fortunately, she was not. But these generally happen in rural areas. And as I mentioned, prior to the 2013 outbreak, would be relatively small and not cause, a huge global problem or global concern. And indeed, people used to say to me, why do we even bother worrying about Ebola? There's more people who do research on it than have ever had it. And I don't think that was true, but nevertheless, I think that we also have to be a little bit more sophisticated in how we look at emerging diseases. And it's not so simple as just counting up the number of people or number of cases we have and saying, okay, well, this one doesn't have very many, so it's not important. And this one has more, so it is important. If you look at the costs, in addition to the financial costs for the Ebola outbreak in West Africa. So $2 billion lost in economic growth in 2015. But look at these other elements: smaller harvests and food insecurity, school canceled for a year. I mean, I don't know how many parents there are in the group, but if you think about, your child just missing a year's education and what that brings, not only for the school learning that they don't receive, but also for young children and the socialization and the growth that we have at that age. So these are, very significant elements. And then the excess deaths that we see, and we're challenged with this with COVID-19 as well. When we have large outbreaks, all our resources tend to get focused on those outbreak-prone diseases. And so, but the other things are still there. So how do we treat the malaria, the HIV/AIDS, the tuberculosis, all the other things? And you're familiar with this now from what you've seen in Japan and what we've seen around the world of struggling to keep the other services in place while the outbreak is ongoing. And here in Geneva, as I mentioned, where I am today, so the university hospital is now converted basically to an all, because of the very big increase in cases here in Switzerland, a very dire situation, serious situation as well. So the University Hospital, for example, has recently, just a few days ago, be converted to an all COVID-19 hospital. So all the services are oriented towards COVID-19. And then, of course, what do you do? There are plans, but we can't fool ourselves that they're as efficient as they were before, in terms of, if you have a heart attack or you have TB or you have other things, where do you go and how do you get the treatment that you need? So it's very disruptive. It's not just a question of adding up the numbers of cases. And so, we ask, why did that outbreak in 2013 through 16 in West Africa, how did that get so big? How did we go from a situation where Ebola outbreaks were always these small little things that would happen in remote areas, usually in Central Africa, and then this thing where we had 30,000 cases, probably more if we could have really counted them all, across West Africa in these three countries. And I've put a few things here that you can see. First of all, I've superimposed the landmass of Guinea, Sierra Leone, and Liberia on the Democratic Republic of the Congo. And so first of all, you can see that this is a very much smaller landmass, but you can also see from the table there that the human population density is much larger. So this is a very densely inhabited area of the world compared to where we had previously seen Ebola outbreaks, and then this is a study that we published last year, I guess, maybe a year and a half ago, in the New England Journal. You can look this up. Just a small thing, looking at the road networks in sub-Saharan Africa. And so if you see this graph here, the red basically is the density of roads. And if you look in the, for me at least, it's the lower right-hand corner, you can see the Democratic Republic of the Congo. And you can see, sure, there's roads that dot that in different areas, but still many pristine areas and isolated areas. Now look up in again, for the upper left-hand corner for me, looking at Guinea, Sierra Leone, and Liberia, and those three countries. And look, the map is almost completely red. And so this is an area that is very, very connected in the world, with one from another. Recognize also that if you haven't spent much time in sub-Saharan Africa, all those lines on a map that delineate borders are really fantasy, right? These are colonial constructions that in different areas, British, French, Spanish, Portuguese people in the colonial era set up these borders, but they mean virtually nothing to people there, really. And so the borders are often, when you go to a border, it's really no problem to cross, and people living on different sides. I recall in southern Guinea one time being in a village where the families lived in Guinea and the kids went to school in Liberia. And of course, no one in that town ever had a passport and probably even knew what a passport was. They just cross through roads like you see there. There may be checks at the main roads, but if you would like not to be checked, it's fairly easy to walk down 1,000 meters and cross through the brush. So what happens in these cases? And if you go to what you see here with the cars, this is the taxi stand in the town of Kyoto-U, where we think close to the first introductions of Ebola were in there. And if you go there at 5:30 in the morning, you will find a number of vans and cars and buses that are loading up like this and ultimately pack 12 or 15 people into the van, and then some goats and chickens on the top, and then start out on a road like this that initially starts in the brush and the bush, but ultimately 12 or 15 hours will get to major population centers. And so these are the population centers of Liberia, Monrovia, Liberia, Conakry, Guinea, and Freetown, Sierra Leone, that are millions of people. And then if you go to the bus stations in these large cities at 5:30 in the morning, you will find the same process of buses and vans being loaded up that will then fan out to tiny villages all across the country. It may take 12 or 15 or 24 hours to get there, but nevertheless, so we have this travel that goes back and forth. And so this was really a problem in terms of control. And if you think about controlling an Ebola outbreak, it's really an analogy of kind of fighting a war on different fronts is appropriate. So what do you need each time there's an Ebola outbreak? Well, you need, first of all, a place to treat people. There's two goals of this. We need to treat them, but we also want to make sure that they are isolated. I mean, it's not just isolation. We need to have an ethical duty, of course, to give them the best care possible. It's not always simple, but so we need a place to treat people, and we need all the equipment and educated doctors and nurses and clinicians to do that. We need all the logistics then of contact tracing, and so people who know how to do that. It's not particularly complicated in terms of its general principle, but you need to speak the right languages and know the geography and be able to find people and be able to talk and explain to people. And so a lot of things that need to happen there to do the logistics. We need laboratory services, right? We need to know who has Ebola and who doesn't have Ebola. And contrary to popular belief, people who present with Ebola clinically, they don't present, as we've seen in movies and books, with their eyeballs bleeding and their liver turning to soup and things like that. They present with fever and headache and early symptoms that look very much like malaria or typhoid fever or many other common diseases. And so it's difficult to say, even if you're the best clinician in the world, who has Ebola and who has one of those other diseases. So we need a laboratory. And then we need training. Of course, people aren't born knowing how to do this. And even if you've gone through medical school, you probably don't know how to do it. I certainly didn't learn too much about the field that I focus on in emerging infectious diseases and viral hemorrhagic fevers. I didn't get that from medical school. Most of you won't get it from medical school. You get it from specified, specific training later on if you work in that field. And then, of course, there's all the logistics, right? So if you say, well, we think we need to follow up suspected cases in these 5 different villages today that are in different directions. Well, you have teams that need to be trained, but they need to get to those 5 different villages, which may be long distances and rough roads in some cases. And so you need motorcycles and cars and drivers, and then you need communications and phones and networks and things like that. And then often, because these events are so turbulent for communities, they're very difficult to accept. We won't have time today, but they come on often in a history of considerable destabilization in the colonial and then post-colonial periods. And so security is often a concern. And so we can do that and put all this in place in one place. And so if we look at the Ebola outbreaks over the years in a small town, we say, okay, we can set all this up. But what happens, as it happened in West Africa, when you say, okay, well, Kyoto-U, that's where it started, and we put everything in place. But then, unfortunately, a physician who fell sick with Ebola decided that he would get better care if he took a taxi 1,200 kilometers to the capital of Guinea, 12 hours away, to Conakry. And so he did that, stopping for the night with his family in a small village, Dabola, in the middle of the country, infecting people there and then infecting people in the capital city. And so then now we say, okay, well, we have to set all that up, not only in Kyoto-U, but also now in Conakry. But now a case has slipped across the border to Kono in Sierra Leone, and so we have to set it up there. But now, okay, some cases have gone to the capital or to Kenema, Sierra Leone, and then to Freetown, Sierra Leone, and then to Monrovia. And so how many different fronts can we fight on? And very drastically and rapidly, we saw that our resources globally and locally were outstripped, and we were losing the battle in terms of putting that up in all these different places. And we've also seen the challenges. I won't have time to go into this, but my team and myself have been quite involved in the large Ebola outbreak, the second largest on record, that happened over a few years in eastern DRC and North Kivu. And this outbreak, fortunately, has been now halted. We have another outbreak on the other side of the country, the extreme western side of Democratic Republic of the Congo, that is ongoing. Although things look relatively favorable, we haven't had new cases in some 30-odd days, but challenged in eastern DRC to fight this outbreak by the extreme destabilization and militarization of that area from over 150 different armed rebel groups and militias that were engaged in a lot of different things. Some of it was about controlling resources. Some of it essentially are business interests. And so, unfortunately, it's very difficult to put in the processes when you have to worry about the security in such an extreme way as we did in that area of the world. And you can see here, this resulted in on numerous occasions, and I'm sure you all were aware or read a little bit about this. This is a Ebola treatment unit that was burned down in a village called Katwa. And so this, of course, really complicates the whole already very challenging endeavor. And, this brings me to a point that I always come back to, that, we can't just think about emerging diseases or really all of infectious disease or health as only a scientific endeavor, a scientific challenge. It's really a human rights challenge. And so it's not by chance, who gets sick in the world. And so we see that people who get Ebola are people who lived in really the poorest areas of our planet. And it's not that Ebola might not be introduced in other areas. It could be introduced in other areas of the world and has been introduced through imported cases, but we don't see onward transmission there because relatively the right to good health care is maintained. And so people get the care that they need, and clinicians have the protections that they need. And so we are not going to have a large Ebola outbreak in the United States or Japan, even if we have the odd case that may get there. And we have seen cases of hemorrhagic fever, Ebola, and Lassa, for example, another hemorrhagic fever that have been imported to Japan, but without having large outbreaks. So it's not just about the scientific progress. It's also really about thinking all the factors that come into this, and that on the social, biological, and health and human rights that underpin these events. This is an example. And Ayako, can I just ask you how I'm doing on time? I don't have I'd have to take my slides down to see, but.
I think since we are having a great opportunity to hear your lecture, please take your time. Don't worry about timing.
Okay. Thank you. So, I think we're not too far off anyways, but this is a study that we published some years ago now, though. And the point of this study is if we look and when an Ebola outbreak is declared, and then we look retrospectively when the first case was, in at least years ago, it was almost inevitably months ago that really things started before we recognized it. So you would have one introduction from the wild into humans, and then it would take a while before that would start to percolate down and get enough transmission and clusters of cases where concern was expressed, or maybe early on you might have a cluster of cases within a family that was interpreted as being something else, either a different disease, malaria, or sometimes interpreted to be sorcery, witchcraft, or curses, or poisonings, or different things. And eventually there'd be enough concern. Unfortunately, many of the times what tips us off is when healthcare workers start to get sick, and eventually someone will get a blood sample and send it to a place where an Ebola diagnosis can be done. And then we will confirm that it's positive and say, okay, now we need to provide the support and all the things that I just mentioned and showed to you in a few slides back. But we're always late, because then when we go retrospectively and look, and it's not always easy to figure out what happened retrospectively, because a lot of patients and people have died, of course, and so the trail might be difficult to figure out. But as we go back, we see that it really all started months ago. And so what we see in the movies and what we think, is great, well, okay, we can get a team into the field in 24 hours coming from London or Geneva or Atlanta or Tokyo or wherever it may be. It's not that we shouldn't do that, but we have to realize that that's not really the thing that makes the difference, right? Because if we say, well, our team can get into the field in 24 hours, that means that things have only been going on, for example, for 59 days rather than 60 days until we're able to respond. So it's important, and I don't mean to minimize the importance of the response that comes from resource-rich countries, but really the control and the importance is developing the capacity in the trenches in low and middle income countries where we're seeing these sorts of events start. And the reason that these events are starting there, by the way, are because those are the places where, since going back to one of my first slides, that these are zoonoses coming from live animals into humans. Of course, those of us in Switzerland or London or Tokyo, most often we don't have too much contact with live animals. And so if we ate an animal source for, a meal today, probably we didn't kill it ourselves. We bought it at the market. And so that chicken or pig or whatever it may be. But in many areas of the world, that's still not the case. And so that connection to live animals is still much more common in low and middle income countries. It is also common, and we see, and we won't focus on it today, but we can also see it in richer countries, of course, with industrial farming, where there is considerable contact with animals and from certain high-risk groups. But so we've seen that it takes a long time to really make the diagnosis of these things, and so it's the response in country that's the most important. I put this slide up. This is a laboratory that when I worked for US CDC years ago, we were able to put together a very small laboratory that worked primarily on Lassa fever. And it just by chance was an hour and a half down the road from where this Ebola outbreak started. But the Ebola outbreak started much later. And this laboratory, we lost funding for this after the World Trade Centers were destroyed. Because most of the interest then turned not to Ebola in sub-Saharan Africa, but Ebola as a bioterrorist agent. And so could it be introduced into the United States or into other countries? And so the focus really on kind of building capacity in sub-Saharan Africa was lost. And I often wondered, how different it might have been had this laboratory still been functioning in 2013, where people would have been able to say, oh, well, since maybe this could be one of these things, these hemorrhagic fevers like Ebola, why can't we just drive a sample down the road an hour and a half and check that and see if Ebola is ongoing? And maybe it could have been diagnosed in country, in Guinea, in the days, weeks or after the first case, before things really got out of hand, rather than, as it was, being diagnosed 3 months later in laboratories in Germany and France. But this was a lost opportunity, and again, an example of how building the capacity in country is extremely important. And there's very good news on that. And so I mentioned this earlier. So the diagnostics technology is really coming along. And so things that we couldn't have really dreamed of doing beforehand are coming along. You can see the laboratory inside the tent is a mobile lab that was set up in Guinea during the outbreak there for Ebola. But now we're starting to see really technologies like gene experts. You can see that machine there that are very robust, relatively easy to operate, and coming down in price. And so it's not the sort of thing that every hospital in the world is going to have, but it is the sort of thing that we can anticipate that reference centers in almost every country in the world, including in sub-Saharan Africa, could have now, that don't need incredibly high-tech educated technicians or high-tech reagents. Again, the cost is not so low that every hospital could have them, but if you have a reference center and a well-known supply chain and information on where to send a sample, I think we are getting beyond the era where we have to depend that Ebola and some of the diagnostics for emerging pathogens have to depend on diagnosis from the United States or European countries or Japan or where it may be, and then this will of course really enhance things. And then even going further, we have, this is an example of just one, there's numerous ones now, but the MinION is, these are really very small portable units that can help with sequencing, and the sequencing can be very illustrative regarding the provenance of a virus and where it's coming from, and has helped us in Ebola outbreaks to figure out whether a given outbreak or a given cluster of cases is due to a new introduction from an animal or from reintroduction from a human survivor, and sexual transmission from virus that's maintained in the semen of men. So these tools are not yet to the time where we can say, no problem, just put this in place in every country, but we are getting there. And we are seeing, for example, in the Democratic Republic of the Congo, in the last few Ebola outbreaks, the diagnosis has been done at the Institut National de Recherche Biomédicale in Kinshasa by local investigators and who have the right tools. And so we were increasingly less dependent on outside sources. And so that's really a very important part of what's happening, and a very favorable part. More challenging is we still have a huge problem with the healthcare labor force in the world. And so, what we saw in West Africa for the Ebola outbreak was, first of all, these were areas that had very few healthcare workers to begin with. If we took Liberia, all during the Liberian Civil War, the medical school was closed. And then as it opened after the Civil War, it graduated an average of 17 doctors a year. And so 17 doctors a year for the whole country. I don't have statistics on this, but I would speculate that a good number of those doctors were probably outside the country, working the so-called brain drain, where doctors can, of course, educated people can make more money outside the country than inside the country. So you have very few healthcare workers to begin with. And then I'm sure you all paid attention to this, years back, that without the right protections, healthcare workers were getting Ebola themselves. And so the disease was decimating the healthcare workforce. And then at that time, for diseases like Ebola, this picture here that you see was a training. I was part of providing the first training to U.S. physicians at the time who were not familiar with taking care of patients in these settings. And so we really needed to completely create the workforce. And we're still quite vulnerable with the global healthcare workforce, something that Director General Tedros at WHO would like to address, but have been so caught up with Ebola and then COVID-19 outbreaks that it's difficult to really address it. And the other major component of this, of course, is access to care. And so surveillance systems really depend on people having access to care. And in many parts of the world, that's still not assured. So, but there are a lot of things that are happening in terms of information sharing that are changing the dynamics really of response. And I'll go into this more next week in our lecture. You can see this knowledge sharing hub from our group, the UK Public Health Rapid Support Team. And so the forcing us into remote working, of course, has enhanced this, and we're able to, with the technologies and with the information sharing, able to reach populations much more easily than we might have been able to do in the past. And then there's really great leadership that we're seeing, especially in sub-Saharan Africa, but other areas of the world as well. And we look at some colleagues of mine and people that I admire and learn an incredible amount from, and Chikwa Ikwezu, who's the director of Nigeria CDC, John Nkengasong, really an inspiring leader of Africa CDC, Shidi Mweti, who is the director of the AFRO, the regional office, WHO regional office for Africa. And so, there's really great leadership that we're seeing that we didn't necessarily have. So, and the political leadership is incredibly important, because I just put out some of the positives. I won't go through examples of leaders who haven't been doing such a good job, but I think you can guess for yourselves places that I think where we haven't respected that science is a real thing. We need to believe it. We need to fund it. We need to base policy on it and communicate it honestly and transparently. And saying that that an outbreak will just disappear and it'll go away, or it's not real, or politicizing this is, of course, not to anyone's benefit. It's a public health emergency, not a political emergency. And so, that has been a huge challenge in many areas of the world. I come back to this, that we need to recognize that it's not all about the biomedical components. If we look at our team, and I'll tell you more about our team and what we do next week, but we've only existed for the last 4 years, and we've responded to, I don't know, 15 or so different outbreaks around the world. About half of those outbreaks are diseases that are there for which there's a vaccine. So that tells you it's not all about biomedical innovation. We don't necessarily need a new tool. The tool is always already there, but just for various reasons, the tool has not been used in order to protect the populations at risk. And then we also have an area, if you looked prior to COVID-19 and said, really, what's the biggest problem in terms of outbreaks in the world? People probably would have said Ebola in Eastern DRC, and of course it was, but the real answer would have been cholera and Yumin, where this is an old slide now, certainly way over 1 million cases and way over 7,000 deaths. But of course, the real solution to this, it's very difficult for any of us to really provide support because the political environment is so chaotic and so insecure that we, for example, our team, we just don't have the possibility of providing support because we don't have the security operations that we would need in these sorts of settings that are very insecure. So take-home points on outbreaks and control from today. The zoonotic interface in the viruses, especially RNA viruses, are areas that pose the biggest threat to us. Another area, of course, is antimicrobial resistant bacteria. The response in the trenches and not the international outbreak response is the rate limiting step. So it's not people like me coming from London, which doesn't mean that it's not useful for people like me to come sometimes, but it's really the longer term response and building that with our partners and working, and we do work very closely with Africa CDC and Nigeria CDC and different ministries of health. And our goal is to really create the capacity overseas and ultimately so it's not dependent on people flying in from another place. And then I didn't have too much time, but multiplex diagnostic strategies are crucial. Astute clinicians and good epidemiologists will always be needed. And what I meant by this was, and I talked about some of the new diagnostics, I think we are looking at an era, a future soon where, in the next 10 or 20 years, where the question of what's in a sample is really not too hard to answer. So we will probably ultimately laboratory diagnostics. Right now, the expense and technology is not quite reachable, but ultimately we won't have any need for a priori assumption of what we're looking for. And so rather than saying, test this for Ebola and Marburg and Lassa, you will say, well, let's just do unbiased sequencing on this, and we'll see all the organisms that are in it. The reason that I use the word organism rather than pathogen is, of course, in one of our challenges will then be is that we will find numerous organisms, and many of those may be colonizers. And so when we're seeing that body cavities and fluids and areas that we thought used to think were completely sterile spaces, now we find organisms in there. And so that may be completely normal and completely even desirable, right? It's like doing a culture of your skin. Of course, if you culture your skin, you will find different bacteria that grow, and you should have those bacteria that grow on your skin. You need those bacteria on your skin. Doesn't mean they're pathogens. So our challenge will be to figure out now what is a pathogen and what is a colonizer as we then take a sample of blood or urine or sputum or whatever it may be from a sick person and have 4 or 5 different things. It'll be fairly obvious when there's an Ebola virus in it, but it may not be as obvious when we have lots of different things, and pathogen discovery will be enhanced, but we'll still need good clinicians and epidemiologists to figure out what's really going on. And we have examples of making the mistake of saying, aha, we grew something or we found a pathogen or we found an organism in a given specimen and presume that was the cause of the disease, where in many cases it may not be. Moving on then to other take-home points, developing the biomedical public health and research capacity in low and middle income countries is in everyone's best interest. And the reason I put this in here is to counter in some settings where we have people in the world who live in resource-rich countries that say, well, why do I need to care what's happening in Democratic Republic of the Congo? It's not my problem. I live in the UK or the US or Japan or wherever it may be. Why are my taxes going to send someone to the Republic of the Congo or Sierra Leone? And, I would first of all argue that, of course, just on ethical grounds, that I think that's the first reason and don't really need more of a reason for that. But I would also, if that's not enough for you, I think on strategic grounds, it's extremely important. And so, the example that I use, if you come out of your house or apartment sometime and you see that there's a fire down the street and you're worried about that fire coming and burning your house or your apartment, the best way for you to do that is not for you to sit with a bucket of water at your door, right? The best way is for you to take that bucket of water and go down the street and put that fire out. And so there's strategic reasons as well as ethical reasons for thinking that what happens in low and middle income countries is really of interest and importance for all of us, regardless of kind of where you stand on that. And then recognize that that really the people suffering from this disproportionately are the poorest populations in the world in general. May not always be true, but I think even if we take COVID-19, it's often true in terms of the death rates that we're seeing in many areas of the world. So it's not just about the biomedical parts of this. It's really about advocating for health as a human right, and important if we recognize health as a human right and shape policy around it. The importance about that, it's not just a statement to make us feel better. The importance really is that if we accept and all accept, and if governments accept that it's a human right, then we have the next question of how do we implement it, right? How do we fund that and make that happen, and something that is doable. So important, I think, to give that context. I'll end with a few shameless plugs for different things. I'm not sure how familiar people are with this society, the American Society of Tropical Medicine and Hygiene. So this is, although it's called the American Society because that's where it was founded a century ago, this is really an international society. Normally I would be inviting you to join us for our annual meeting that would happen in Toronto, Canada this year. Because of COVID-19, of course, the annual meeting is not happening in person, but actually that provides an opportunity for you to join us. It's all still happening, but it's all online. And so consider joining us. I think this is a very active meeting, usually around 5,000 people who would attend this. And I would say, really kind of the experts from around the world in tropical medicine and global health. And so, for example, a COVID-19 session will feature Tony Fauci from the National Institutes of Health in the United States, Richard Hatchett from CEPI, who works on vaccines and vaccine distribution, John Nkengasong, who's the director of Africa CDC, and Heidi Larson from the London School, who's really a global expert in vaccine acceptance. And so, and there are other sessions really on race and social justice in tropical medicine and global health, on planetary health and climate change and how that impacts the way we look at disease. And so, and then everything. Sorry, I have my cat here who wants to say hello. And so, really quite an active event that you can tune into registering. I'll also put in a plug here for, on a much smaller scale, this is a non-governmental organization that I was fortunate to help found many years ago, Doctors for Global Health, that doesn't work really so much on the technology sides, but on the human rights and accompaniment side. And I'll encourage you to check that out as well. A few supplementary readings if you want to check out read a little bit more about these things. And I think that's my last slide, Ayako, and we can happy to entertain any discussion or questions. Thank you.
Thank you so much, Professor Bausch. Such a wonderful lecture and many insightful things that we have learned from your lecture. So I'm sure that the participants would like to ask questions. If you have any questions, please put your microphone on and ask questions. If you want to raise your hand, I can also call you to respond. Any questions? I know people are a bit shy. I think I want to start by asking, and maybe other people can see if you think about please question, please. I guess what I would like to ask is your experience of visiting all these developing countries. I'm sure you will have a lot of unexpected things while you manage things there. Can you give us stories or your experience of what will be the most challenging things for you?
Yeah, it's a great question, and you're right. There are many unexpected. Sorry, my cat is insisting on being part of the program, but there's many unexpected things that do happen. I would, two things that are challenging. One is that we, of course, take steps to limit it and hope that it doesn't happen, but it's not impossible. On occasion, it happens that either you or a member of your team gets sick, and that can be, sorry, that can be especially challenging in of course, if you think you have the target disease, right? So if you come down with a fever and a headache and you're working on an Ebola outbreak, then and thinking you might have Ebola, as you can imagine, that's a very high stress event. And so what I've learned, and sometimes it has happened, not with me, but it has happened that people do have Ebola. So, in Gulu in 2000, in Uganda, there were 2 Ebola treatment centers, one of which I directed, another one which a Ugandan colleague directed. And 2 months into the outbreak, he came down with a fever and a headache and proceeded to progress through full-blown Ebola and died. So, these are very, very emotional, difficult periods for people to go through. And so, that's one of the challenges. And how do you deal with a sick person, or when you get sick? What I've learned from that is really is that the science always guides you, right? And so if you say to yourself, there's no way that this person could have Ebola. They had no contact. They're an epidemiologist who has no contact with sick people. They don't work in the lab, no contact with blood or bodily fluids. The 99% of the time, the science is right. And so if you say there's no way this could be Ebola, you still have to, of course, go through the process of testing and ruling it out. But really, you'll turn out there's no way this could be. And if, in contrast, you say, okay, this is a person who had contact. And, when I worked in Sierra Leone during the Ebola outbreak there, quite a few colleagues, African colleagues, in a very difficult setting where we did not yet have the right protective materials. It was a very difficult emotional time with almost every day a colleague coming to me and saying, I have a fever and a headache, and testing them. And very sadly, many of them and close friends did come down with Ebola and die. So that's, really one of the challenges that you often have. And then the other challenge can be the insecurity. And and we have to take this into, the appropriate context and understanding. And so, we often might look at populations who are resistant to some of the measures that we put into place. And we might react, how stupid are people to be resistant? How come they can't obey this or that? But at least in the setting of sub-Saharan Africa, I think you have to put that in the context of, many centuries of, first of all, colonial rule, and then not local rule after independence that was particularly understood or upheld principles of justice. And so in many of these places where there's been civil war, so appropriately, populations that have historically thought, okay, people coming from either colonial governments from the outside or the new governments post-colonial, they are politically motivated for their own power. And we have to recognize that that was really often true. And so now we have someone who me coming from London or the United States, or someone even coming from Kinshasa to Eastern DRC, thousands of kilometers the other side of the country, and saying, well, here's this new disease that you've never heard of. Most people hadn't heard of it, that you should do this and this, and it really affects your life economically and socially. So it's not surprising or stupid that people have considerable suspicion about that. And that can that can at times result in violence, and especially sometimes it's more the unfortunate kind of militias and wanting to control things for their own power. But it can also be violence of just the angst and the struggle that these communities go through. So you can imagine, I've been in settings where a family of 12 has 10 people who died of Ebola. And how much of a struggle is that for you emotionally? I think understanding that your reaction may be, quite a violent one to begin with. And so that's something that we do have to work through. And there were some tense times I can remember in Guinea with trying to go in a burial of a woman who had died for Ebola, and the husband was quite upset, and the villagers coming around quite upset. And the wife had recently died, but numerous other family members had died before her. And so, it was really an emotional time for them. And it came out in a way that was potentially very violent. And we had a very nervous afternoon there. And in that case, everything worked out okay. But there have, as you've seen, it's not always okay. So we do have to figure out, how to deal with that in a humane way, but also with the appropriate security.
Okay, thank you so much. We have one comment in the chat question. Would you like to ask question directly to Professor, or?
Okay. Hello. Do you?
Yeah,
hi. Thank you very much for your such interesting lesson. And I am from Mongolia. My question is related to the COVID-19, and how are you thinking about the wide vaccination? Will stop this vaccination the spread of the COVID-19? What are you thinking about this? Even if we don't have if we don't have vaccination, how long time will be spent spontaneously over COVID-19?
Yeah. Okay, great. Thanks. That's a great and key question. I won't say that I have the exact answer. I don't think anyone knows the exact answer. I think we're going to have to look as that vaccine as one contribution to global control of COVID-19, but not as the contribution or the solution for various reasons. So first of all, we're still a ways away from a vaccine, and you can see different predictions as to when we will go through that, but we're only it depends on the vaccine, there are over 200 different candidates, and we don't know which ones are really going to come through. They're in various stages of phase 1, phase 2, and phase 3 testing. It should be said that many products, if you look at the history of product development in vaccines and therapeutics, most products that go through phase 1 and phase 2 fail in phase 3. And so we shouldn't be overly optimistic. It's not actually particularly hard to create something that is immunogenic. So the fact that you have antibodies produced from a vaccine does not in any way necessarily mean that it will be protective. So I think we still have a ways to go in terms of producing a vaccine and showing that it's efficacious. That is on a fast track of people working on it as fast as they can, and certainly the regulatory agencies are poised to approve it as fast as they can. Hopefully respecting safety, of course, because it would be a catastrophe, even though we want that product as fast as we can, it would be a catastrophe to really have a product out there that's not safe. Not only ethically, of course, we want a product that's safe, but we have to be cognizant that the concern over this vaccine, I'm sure you've all seen, and the anti-vaccination movement is very, very strong as well. And so if we have a product out there that is not safe, or even if it appears to be unsafe, we can have a strong backlash against it. So we still have to get to the product, but we also have to get, of course, access to broad numbers of people across the planet. And even if we said, okay, tomorrow we have a vaccine that's gone through phase 1, 2, and 3 testing, it takes considerable production and organization capacity if we wanted to vaccinate the entire planet's population of 8 billion people, to produce and distribute 8 billion vaccines, and all the issues that we would need to work through in terms of access and equitable distribution. It's not that these are new ideas, that the people aren't working on them now, but I think we have to realize that they will be complex. And then I think there's still some basic science things that need to be answered. So we don't really understand yet the correlates of immunity. And when you think about, what we all believe based on the still relatively limited data, that there's probably reinfection with COVID-19. And so the first infection does not necessarily confer lifelong immunity. And we don't really know how long it does confer immunity. The question's not answered by just looking at antibody levels. Cell-mediated immunity can still be there in the background, even if antibody levels wane, but we just don't really know yet. But if we take into account the possibility that the wild type infection, does not confer long-term immunity, and we don't understand really what the correlates of immunity are, it's not certain that a vaccine will produce long-term immunity. And so then we have a challenge with how often do we have to revaccinate, of course, people and to create immunity. So that I think is, I think a vaccine is one tool, but I think we're going to have to really approach this. And in some ways, we've made this incredibly more complex than it has to be. I think the tools that we have, the tools of I wasn't originally a proponent of this, but I think the data have shown all of us that masks really can help in terms of limiting the transmission. And so, really, if we were to, as a society with no exceptions, if we were to have really the responsible behavior in terms of mask wearing, physical distancing when out in the community, and hand hygiene, I think those tools alone would actually be very significant in terms of getting a control of this problem. And if we could use those tools effectively, not only would the vaccine, we're always going to want a vaccine, but we wouldn't be as reliant on a vaccine. And also, it would allow us to have some semblance of normal life. It doesn't mean it wouldn't go back to normal life, but we could keep economies at least functioning, and to a better degree than we've been able to keep them functioning in many areas of the world, and not have to get into these questions about lockdown or not lockdown and things like that. So I think a vaccine is going to be an important tool that we're pursuing, but I don't think it's going to be the answer and the solution that is just going to make everything okay. Often the last thing I'll state, and because I know we're probably getting close to time, but is that therapeutics, I think, can be, are talked about less, but if we get a good therapeutic, that is easily administered and we can distribute that. Think about how much this would change if we were able to say, oh, you have COVID-19, don't worry about it. We have a good medicine to give you. You can take this at home, or you'll be in the hospital for 2 days, and it will reliably prevent people from progressing to severe disease. So that would take a lot of the pressure off, right? And we still want to limit infection and limit transmission. But if we could say where there is transmission, it's not such a catastrophic event, that would be really, quite an important avenue to pursue as well. And those studies are ongoing. We've not yet really understood or gotten to the right answer. We have some drugs. Remdesivir can help for severely ill patients, but the benefit is modest. And then steroids can help people who have severe disease. But what we really want is something that we can say, okay, whether you're symptomatic or asymptomatic, take this drug that we can give to you, these pills to take at home, like we would treat a urinary tract infection or a strep throat or something like that, with confidence that this will prevent the vast majority of people from falling ill. The other part of that is that if it limits the duration of virus shedding, it would be an important element and to control spread. Somewhat similar to cholera, for example. People get better if you get people the hydration they need. They get better from cholera without giving them antibiotics. The real reason to give them antibiotics when they're sick is that it limits the shedding of cholera in their stool, and so then you prevent the transmission. So a therapeutic that would help people to stay well and also limit the period of infectivity would also be a very significant contribution.
Mm-hmm. Thank you very much.
Thank you, Professor. We have another question.
Thank you very much, Professor, for your wonderful presentation. Actually, my question is, being as a public health expert, do you think that WHO announced COVID-19 pandemic a bit later? And if this precaution was taken a bit earlier, so there weren't so much mortality from this disease? So what's your idea on this?
I mean, there is no doubt that in many places in the world. So I guess I'm not sure if your question is about, whether Chinese authorities should have announced it earlier, or whether in different places.
No, it's WHO, from Directorate of WHO. Yeah.
I think I think WHO is doing their best with a very difficult situation. And we have to also look a little bit at the historical context. So WHO announced the 2009 H1N1 pandemic very early on. And a lot of people ultimately were quite upset with them for announcing it very early on, because they said, okay, here's the influenza pandemic that's going to happen. And people expended a lot of resources for what turned out to be a relatively mild disease. And so people said, why did you get us all nervous and spending all our energies and resources and money for something that turned out to be mild? And so, and I don't use that as an excuse, but I just use that as to help you understand that when from a WHO and a global perspective, you're always in this difficult period. You can't see the future. You don't know what's going to turn out to be a big thing. If you say early on, this is going to turn out to be a big thing, divert all your resources, put into place all your emergency operation centers, get ready for, the big one to hit, and it doesn't hit, like was the case for H1N1, you're open to considerable criticism. And of course, if you don't say that, and then it does turn out to be the big one, you're also open to considerable criticism. Should WHO have perhaps acted more rapidly? I think in hindsight, we can probably say everywhere in the world, we should have acted more rapidly and implemented protections. That's certainly true in the UK. It's certainly true in the United States and many other places. But I think we also have to just understand kind of the context that we're in. I don't want to be accusatory. I think there are places in the world that should have acted earlier and would have known that they should have acted earlier, where they took this as a political rather than public health priority. And some places that still need to act, and other places where it's just a very challenging public health process to try to figure out, how to to act. But of course, recognizing that sure, we want to limit transmission, but we understand the huge impact that this will have economically globally, and trying to limit that as well. I know that's not a complete answer to your question, but I do think it's a complex question that is sometimes oversimplified, which isn't to say that we shouldn't be pointing the fingers where it was clear, but often it's a little murkier.
Thank you very much.
Thank you so much. I know everyone wants to continue to listen to your stories, but the time is running up. And so let's thank Professor Bausch. If some of you can show your face to appreciate, can you show your face and thank him?
Thank you, Professor. Thank you so much.
Yeah, thank you, and thank you for showing your faces. I really, in this time of remote working, I do like to see some faces. So it's nice to see you. I look forward to talking with you again next week.
Yes, so we are having a second lecture next Monday, November 9th, at the same time, 6 o'clock Japanese time and 9 o'clock UK time. So please join again, and please also tell your friends. This is a very good opportunity, so I hope more people will be attending. We'll make another announcement to the Kyoto University, but hopefully more people will join. So once again, thank you so much, Professor Bausch, and see you next week.
Thank you so much.
Thank you. Have a good evening. See you next week.